in Houston, and I said, if I ever have to have somebody speak on pulmonary hypertension, I will have Dr. AdaaniFrost speak. It was dynamic, it was exciting, and I loved it, and I haven't forgotten it. And every year we try to bring a topic to you that I think we don't diagnose and treat well, or not enough. And so I'm very, very pleased that Dr. Frost, who is professor and director of medicine at the esteemed Baylor College of Medicine in Houston, has accepted our invitation to speak to us. So welcome, Dr. Frost.
Thank you very much, Dr. Kahn, and I could absolutely kill you for making me come up here after that talk by Dr. White, because that was, it's a really hard act to follow. Anyway, I very much enjoyed that. So pulmonary hypertension is really something, a fairly large digression from what you've just heard about. What you've just heard about is a disease that afflicts huge numbers of the patients in the United States. What we're going to talk about now is a very, very rare disease that affects maybe one patient in a million. But one of the reasons I'm interested in it, and it's important perhaps for you, is because this disease, high blood pressure within the blood vessels of the lung, is sort of a template. It allows us to understand better the pulmonary vascular bed, just as the understanding that Dr. White just brought to you about peripheral vascular disease and the ubiquitous nature of vascular disease affecting all the vessels in the body gives credence to a better understanding about peripheral vascular disease. Pulmonary arterial hypertension allows us to understand what happens in the vascular bed of the lung. Is this forward?
That's correct.
Okay. So I'm going to talk to you about pulmonary arterial hypertension. Unlike Dr. White, I am owned by almost every drug company you can think about. So I have many, many competing interests, partly because this is a rare and orphan disease. And to get people to be willing to get involved with studying it in large studies nationwide and internationally, that's not going to come from the NIH. It's an orphan drug, and it's totally underfunded from the point of view of the government, or an orphan disease. First of all, so what is pulmonary hypertension? It's just high blood pressure in your lungs. Okay, it can happen with any disease entity, from the left-sided heart disease that you heard alluded to shortly before, chronic thromboembolic disease, severe lung disease. It's basically just high blood pressure in your lung. And when it is present in any of those other diseases, it's associated with a much higher mortality. So if you have bad pulmonary fibrosis and you've got pulmonary hypertension, you're way more likely to be dead in a year than if you don't have that pulmonary hypertension. If you've got left-sided heart disease, you're being assessed for a heart transplant, and you have pulmonary hypertension, not only are you more likely to die, you are also not going to get yourself a heart transplant, because it means that your RV is badly affected, and unless they can do something to mitigate that, you're not even a transplant candidate. So this has huge ramifications whenever it's present. How do you define pulmonary hypertension? Well, if you go back to the old cardiology literature, it's sort of a gestalt. It's a PA systolic of over 40 by echo or by hemodynamics, okay? But now increasingly, in an effort to better understand normal and abnormal, what is true pulmonary hypertension and what's just a variation of normal, they've tried to define it better. And pulmonary hypertension in any form is usually considered to be a mean PA pressure of greater than or equal to 25. Now, pulmonary arterial hypertension means that high pressure of greater than or equal to 25 for the mean pulmonary artery pressure is due to a disease happening only within the small and medium arteries of the pulmonary vascular bed. It is not occurring because of downstream pressure elevation. In other words, the wedge pressure is normal, and is also not a flow-related problem. In other words, if you turn off the water faucet, the pressure goes down. in the pulmonary vascular bed, the higher the flow, the higher the pressure. That's true even in normals up to a certain point. A woman in labor can generate a cardiac output of 21 liters a minute. Okay, that's a high cardiac output. She's not going to have pulmonary hypertension, though. She will not meet this definition of pulmonary hypertension. Lance Armstrong, cycling through the Alps of France on a bike, probably is getting a PA pressure that's significantly elevated, but his pulmonary vascular resistance is normal. So this is not somebody who has a disorder of the small to medium vessels. The interest in pulmonary hypertension originated back from the recognition of a disease entity that we then called primary pulmonary hypertension. It was very, very rare. It was recognized in the early 1900s. Usually young women complaining mightily about being short of breath or fatigued, and everybody would pat them on the head and tell them they were hysterics until they wound up dead. And at that point in time, the pathology demonstrated this obliterative vascular disease within the small to medium arteries, often associated with plexiform lesions. That was the first recognition that there was a disease that could limit its manifestations to the pulmonary vascular bed and result in a horrible outcome. Based on that, a registry was put together at the initiative of the NIH, trying to get a handle on what this disease was. And over about 5 years, 380 patients were screened for pulmonary hypertension that were sent to major referral centers. And of that 380 patients, 180 were found to have the disease, primary pulmonary hypertension. And these patients were carefully characterized. They were predominantly female, about 2 females to every male. The diagnosis, time from diagnosis to death was really only about 2 years. So they did not exactly have a very long trajectory, 2 to 3 years. And in fact, if they were functional class 3 when they presented, and most of them were, their median survival was only 2.5 years. If you were functional class 4, and by the way, this hasn't really changed much, if you don't have a response to therapy, or if you were back in the bad old days in the 1980s when there was no therapy, you're going to be dead in 6 months. So this is still an incredibly mortal disease, and one, in fact, that has a lifespan very analogous to cancer. Okay, and if you think about pulmonary hypertension like a very rare and exotic form of cancer, you can understand how critically important it is to unequivocally make the diagnosis, to try your best to make sure you're not confusing it with something else, and then to initiate the therapy, because now we do have therapies for this disease that are going to make that patient better, but this remains a mortal disease. So how did we get to the point where we could tease out what really is pulmonary hypertension with that sort of disease trajectory, and what is the other forms of pulmonary hypertension, or what is not pulmonary hypertension? And that resulted in a lot of sort of classification of the disease. When doctors don't know anything about something, we spend a lot of time classifying it. You know, it's the redhead with the one blue eye and is left-handed, you know, that's a class. So, but it's actually really important, but as I said, it really does tell you where we were, and to a certain extent where we remain in the assessment and management of this disease, because we're still classifying like mad. So we still don't have a very good handle on it. But it does allow us to distinguish PAH, pulmonary arterial hypertension, from all the other entities that are associated sometimes with pulmonary hypertension. It allows investigators to conduct studies with well-defined groups that have been carefully characterized and have underlying pathogenesis. And on an individual basis, within the diagnosis of PAH, there are also patients who have slightly different outcomes. So classification, while tedious and pedantic, is actually kind of important. So I mentioned that all forms of pulmonary, there are many forms of pulmonary hypertension. We're going to talk about PAH, but it's important to realize that probably the most common form of pulmonary hypertension nowadays is that which is due to left-sided heart disease. 30% of the patients who are sent to our pulmonary hypertension center have left heart disease. Doesn't mean the cardiologists are dumb and didn't know that there was such a thing as left heart disease that does this. But increasingly, there's this entity that has gone from being called diastolic dysfunction now to heart failure with preserved ejection fraction. So these folks have got pulmonary hypertension on an echo. They have got horrible symptoms. They've got manifestations of cor pulmonale, okay? And they have an absolutely normal ejection fraction. And they're a real fly in the ointment for the management and treatment of this disease because we have nothing yet for these people. Obviously, systolic dysfunction is important and valvular heart disease, but much easier to recognize. Lung disease is the second commonest cause of pulmonary hypertension. Usually the lung disease that's most associated with pulmonary hypertension is fibrosis. And increasingly we're seeing, though, a mixed entity of obstruction and restriction. So there are people who have pulmonary fibrosis, but also have emphysema. There is nothing about being a lifetime cigarette smoker giving you risks for emphysema, and if you're unlucky enough to be a familial pulmonary fibrotic, that doesn't mean that you can't get both diseases. Those patients have near normal lung volumes and spirometry, but grossly abnormal diffusion capacities. Sometimes their chest x-rays look absolutely normal. You do a high-res CT scan, you can tease out that that is a parenchymal lung disease that's contributing to their pulmonary hypertension. Chronic thromboembolic pulmonary hypertension is grade 4 or stage diagnostic group 4. And finally, there's a whole catch-all bag of weird diseases that we really don't know where to put them. Gaucher's, lymphangioliomyomatosis, Langerhans histiocytosis, sarcoid, which I actually feel behaves a lot more like primary pulmonary hypertension, but clearly a different pathology. But what we're going to talk about today is what used to be called primary pulmonary hypertension. We now call PAH, pulmonary arterial hypertension, diagnostic group 1. And even within that, there are multiple different subcategories. Some of you may remember from the anorexiant litigation that happened many years ago with fenfluramine and dexfenfluramine, and with the toxic rapeseed oil that was reported mostly in Europe. This onset of pulmonary arterial hypertension, so that is anorexogen associated. We know that the idiopathic PAH patients, which would be what you would call the primary pulmonaries, if you would now, it's not a term we use anymore, primary. That patient population, about 10% of those are in fact heritable diseases. In other words, they either have a family history or we recognize the genetic mutation. We still don't know what a lot of these genetic mutations do, but we're getting a better handle on the things that can trigger the disease by understanding these. There are many others, connective tissue disease. About 40% of all scleroderma patients are going to develop pulmonary arterial hypertension, and when they do, it's going to be their cause of death. HIV infection, 1 in 1,000 of those patients are going to get pulmonary arterial hypertension, and when they do, it is likely going to be their cause of death, not their underlying HIV. Portal hypertension, about 10% of the patients that come to our liver transplant center for evaluation for transplant due to cirrhosis will have pulmonary hypertension. If we can't lower their pressures, they don't get a liver transplant. So they die untransplanted because of pulmonary hypertension. Congenital heart diseases, that's a heart disease, right? That's not pulmonary arterial hypertension. If congenital heart disease was a purely mechanical phenomena, all patients with congenital heart disease would get pulmonary hypertension, and they don't. Something in the order of 4 to 8% of VSDs will get it, about 4% of ASDs, if their hole is big enough and they stay uncorrected long enough. Most ASDs live to a ripe old age and die without having an incidental finding of an ASD on postmortem. So pulmonary hypertension is not a sine qua non of congenital heart disease. Clearly there's something in the genetic makeup of some of those patients that predisposes them to the development of this very morbid mortal disease. Schistosomiasis worldwide is the commonest cause of pulmonary hypertension. Every now and then I'll look for it in one of my patients. I've yet to find one. But it is undoubtedly the cause of pulmonary hypertension, probably because it causes cirrhosis and therefore portal hypertension. And there's some other more exotic diseases that I'm not going to go into. So how does this disease move through? Initially, you've got a healthy person, normal blood flow, normal thin endothelial layer within the pulmonary vascular bed, very little in the way of smooth muscle hypertrophy, because the pulmonary vascular bed is a highly flexible, big capacitance system. You can increase cardiac output through the pulmonary vascular bed 3, 4, 5-fold without making any change in the PA pressure, because you are able to recruit vessels that are not normally full of blood and dilate those that are currently accepting blood. But over time, possibly related to some of the risk factors shown here, the predisposing conditions, the genetic risk factors, perhaps things within our environment, that physiology changes and you start to get endothelial hypertrophy, smooth muscle hypertrophy, more smooth muscles and bigger, fatter ones, adventitial changes. There's a lot of inflammatory change in these blood vessels. And finally, what is really irreversible disease shown here with dense thickening. Now you can see that if you have something that looks like this in your pulmonary vascular bed, a vasodilator is not going to do squat. You need something that is either going to stop that disease from progressing to that point, or you're going to be optimistic that perhaps within that vascular bed of a patient who clearly has disease that looks like this, there may also be disease that looks like this. In other words, more reversible disease. So I'm going to walk you through a patient. And this was a patient that I saw about 8 or 9 years ago. So the therapeutic armamentarium that we had then was quite different from what we had now. But it is a very nice template for an approach to dealing with the patient, and because of the patient's course, it actually introduces most of the therapies and the rationale for their use. So this was a phone call, of course, on a Friday night. There's something about Friday nights. At about 5 o'clock from an external hospital, saying they had a 20-year-old Afro-American male, and he was in extremis. He was hypoxic. He was confused. He was oligodenuric. He had had a diagnosis from another hospital of pulmonary hypertension, and they'd kind of patted him on the head and told him to go home and cancel his subscriptions to magazines because he wasn't going to be around for very long. And that was the sum and substance of the therapy at the time. His only prior hospitalizations ever had been for the symptoms related to pulmonary hypertension in the preceding 6 months, which were multiple hospitalizations for shortness of breath and syncope, which had been really dramatically progressive. He, in fact, had had a diagnostic heart cath on one of those prior admissions at the external hospital, which is when they told him he had PH. Other than those hospitalizations, nothing else. He was a smoker. But no alcohol and absolutely no drug use. Family history completely negative. This young man was actually continuing to work, which is really kind of breathtaking because he actually was working up until shortly before he showed up for this admission. Just tells you that some jobs don't require much effort. He was working as a cashier at HEB in the checkout lane, clearly sitting down. At any rate, on exam, when he showed up, morbidly obese, but also breathtaking edema. He had massive anasarca. He was on 100% non-rebreather. You couldn't get a history from him unless it required a monosyllabic answer, so his parents gave us most of the answers. His heart rate was 120. His blood pressure was low, and this was an appropriately sized cup. He had a gallop rhythm, and frankly, you couldn't hear a heart murmur. You practically couldn't hear anything, but you could hear the gallop because you're going through several inches of edema, dough, obese, and a heart that wasn't making a lot of noise. His abdomen was so obese it was unable to assess its liver, and as I said, he had anasarca. So here you see his x-ray, not really particularly illuminating. I mean, it's a portable, so yes, the heart is big, and yes, he may have some signs of an effusion. Possibly you've lost some of the diaphragm on the left. The lung fields may look a little muddy, but the guy is obese, and that's shooting through a lot of fat to get a look at the lung parenchyma. Labs that we had when he hit the door, BNP 1769, upper limit of normal about 180. Hemoglobin is fine. White count 24,000. Troponin elevated. He has had a troponin leak. BUN and creatinine consistent with the oliguria that had been reported from the external hospital, 34 and 2.9. Blood gases. This is important. pH 7.39, PaO2 on 100% non-rebreather, 59, PCO2, 39. Clearly profoundly hypoxic, but although he's obese and struggling, okay, he is clearly not a CO2 retainer. He's just somebody who is starting to fatigue in the face of effort of breathing. LFTs were normal. His EKG did show a right bundle, and that always makes you worry a little bit about congenital heart disease. Does this guy have an ASD or something? Right axis deviation, right ventricular hypertrophy, no big surprise there. I phoned the other hospital where he'd had the heart cath done. We had them fax over the reports. They were limited. I didn't have any pressure tracings, but his PA pressure, and this was about 4 months earlier, was 84/35. His right atrial pressure then was 34/35. There's old data from the NIH registry that says if your CVP is greater than 20, your 6-month mortality is virtually 100%. This was 4 months ago. This guy was on the slippery side of the hill 4 months ago. And now he's, heading at a great rate to that great big checkout counter in the sky. Anyway, so there were no RV pressure traces, no cardiac output. The cardiologist had done a left heart cath, and that had shown an LV-EDP of 18 to 20. That's really high. And a wedge he measured of about 22. 20 years old, is this just a kid with a really horrible heart? Has he got a cardiomyopathy? What's going on? So at this point, what's the diagnosis? We don't know. So, does he primarily have a disorder of the pulmonary vascular bed? He's 20 years old. Possible, he's obese. No diabetes, no hypertension before, certainly not hypertensive now. Could it be left heart disease? Could it be a cardiomyopathy? I would hope that the cardiologist who saw him before would have been able to assess for that. Does he have heart failure? Is it left-sided diastolic heart failure, systolic, valvular heart disease? The differential obviously still includes embolic disease. One would treat all of these things differently. So before you get out your big gun to shoot some fancy therapy at this guy, you really still need to know what you're dealing with. So there are a couple of ways. I don't know about your institutions, but if I call for an echo on a Friday night at 6, I wouldn't want to be holding my breath waiting for them to show up. Whereas I can get a CT scan really quickly. And this is because I'm a pulmonologist, so we love to not get the cardiologist too involved. But at any rate, sorry, and I'm sure I've just annoyed a whole pile of people. But my partner and I published a paper about 6 years ago, because you get a lot of information from a CT scan other than about the lung parenchyma. And this was actually the CT scan that was done that night. So here you see this huge thing here is his right atrium. The reflective thing right here is he's got a central line in, he's got a CVP, and this monster here is his RV, okay. This little doodah right here, that would be his left ventricle. And this right here, that looks a lot like a postage stamp, is his left atrium, and he does have a little tiny bit of a pericardial effusion and a little tiny bit of a pleural effusion. Now I'm actually going to cheat and show you some other films that we didn't do that night. We did them about a week later because we wanted to be absolutely sure about the issues of parenchymal lung disease as well as clot. And what you're going to see here is a contrast study. Obviously, I'm not going to do a contrast study on somebody with a creatinine of 2.9 who's oliguric. So what you see here is even nicer demonstration. Here's his aorta, here's his pulmonary artery coming into view. That pulmonary artery is approximately twice the size of the aorta. And you can see it nicely demonstrated there. Here you see the bifurcation. This man, by the way, had no clots on either VQ or CTPE protocol. But here again, you will see the fact that that is his left atrium. Now this is not somebody with left-sided heart disease causing pulmonary hypertension. If that left atrium was any smaller, it wouldn't be there. And there's his LV, and you can even see the D sign that they report on echocardiogram. So you have flattening of the interventricular septum. His left ventricular free wall on echo was actually touching his interventricular septum during systole a little bit. You see this massively dilated right ventricle and the right atrium. So we had a clue to that from the non-contrast study that was done that evening. We subsequently did an MRI, and this was done about 3 weeks later, and you could still see the LA. It looks a little better filled, but still pretty pancaked. So how do I explain that high wedge? A heart is a bag in a box. You raise the pressures on the right side high enough such that you get compromise of left ventricular cavity and left atrial cavity. When you stick your swan in to measure a wedge pressure, or when you stick your catheter in to measure an LV-EDP, you are going to measure a high pressure. It is reflecting the fact that there is a constraint of pressure due to the marked size of the RV, the huge load that it's under, such that that high pressure on the right is being communicated to the left. So this is spurious elevation of the left ventricular pressure due to right-sided disease. And what clued us to that was both the CT scan and, in fact, the echo that was subsequently done a little later in the evening, which again showed an RA and an RV very enlarged, and an estimated PA pressure of 55/60. Well, heck, you know, that's better than the heart cath that he had. So this guy must be faking. He's not really this sick. I mean, his PA pressure is clearly a lot better. Please remember that on an echo, a PA pressure is an estimate. It's the tricuspid regurgitant jet plus the estimated right atrial pressure. And the cardiologist estimates the right atrial pressure based on the dilation in the inferior vena cava, the presence of blood flow going in the reverse direction during systole, in other words, shooting out of the RA into the IVC, and the fact that the IVC doesn't collapse with inspiration. And the highest pressure estimate they're going to give you is 20. So it's going to be the systolic pressure plus 20 to give you the estimate in this guy of his PA systolic pressure by an echo. When we put the CVP in, his CVP was 40. So clearly telling you that A, not only is he a lot worse off in many respects than you'd expect from the echo, but one has to always remember that an echo is an estimate. So at this point in time, we feel that this young man has got PAH. Could he still have any one of these different forms of pulmonary hypertension? Sure he could. It'd be better off to treat them if they're there. So where do we go from here? His VQ is negative. We did a connective tissue disease workup, but I really, at this point in time, don't really care if he's got galloping something or other else, because that's not what's going to get him out of trouble right now today. He's a sickle cell carrier. He's not anemic. He's not hemolyzing. That's not an issue. HIV and hepatitis screens subsequently negative. The CT cut down low enough so that we know he doesn't have liver disease. We did an MRI echo, no evidence of congenital heart disease. Those weren't done on that night. So we're going to start therapy. What are we going to start with? How am I doing? We have prostacyclins, endothelin receptor antagonists, and things that target the nitric oxide pathway. These are all the therapies that are currently available today for the treatment of pulmonary hypertension that are FDA approved. And we're going to start on the far right, which is the prostacyclin pathway. Now, we know that there's a reduced amount of prostacyclin in the lungs in patients with PAH. There's actually, on the other side of the arachidonic acid pathway, there's more thromboxane. So we know they have a tendency to vasoconstrict and clot, and at the same time, they are inhibited from the normal production of prostacyclin. So low levels of prostacyclin, which when generated binds to a receptor on a smooth muscle cell to activate cyclic AMP. This was the first entity that we recognized as being part of the pathogenesis of pulmonary hypertension. It was the first therapy that was developed. There was a very large, actually, I'll take that back. There was a very small randomized study of Flolan, which is epoprostenol, which is PGI-2 for the treatment of PAH, that was done now in about 1991 40 patients received conventional therapy, which means basically holy water, oxygen, digoxin, Coumadin if it was appropriate, do what you can, versus the same therapy plus placement of a catheter and infusion of epoprostenol. Endpoints of the study included exercise capacity, hemodynamics, survival, and quality of life. And what we saw was an improvement in hemodynamics, an improvement in walk distance, but even in this tiny 12-week study, an improvement in survival. And then you can criticize aspects of the study. However, this is what got the drug approved, was the survival benefit. And that survival benefit has been reinforced by subsequent observational studies. This one on the right from Olivier Sitbon showed a comparison of survival with Flolan versus similarly treated, optimally treated non-Flolan treated patients, functional class 3, treated in France with everything else that was available at the time, looking at, and these were of course largely historical controls, but within a couple of years, the outcomes with IV epoprostenol versus historical controls. A similar study by Val McLaughlin, epoprostenol versus the predicted survival based on an equation that was generated from the NIH registry. Epoprostenol is, by the new recommendations generated at the Nice World Conference, the #1 optimal treatment for functional class 4. This man is functional class 4. So he was started on epoprostenol, which means a catheter was placed, an infusion was started. We gradually increased it. His cardiac output increased. Once his cardiac output increased, you could actually hear his heart and hear his heart murmurs. His PA pressure on echo actually went up because he started to get forward flow. His renal failure improved. He diuresed massively in hospital, most of it spontaneously, because we were very gingery about giving too much Lasix back then to people with a blood pressure of 90/60. In a week, he was walking in the corridor. But this is what's involved with epoprostenol. A catheter that you wear all the time. The old drug had to have ice packs with it because it wasn't stable. The catheter is a tunneled catheter. There's a risk of infection. The patients had at that time to mix daily. There are a lot of common adverse events with prostacyclins, notably the fact that its very short half-life, a couple of minutes, means that if you interrupt the flow of drug, there's a risk of death. You can get rebound pulmonary hypertension. The drug at that time required refrigeration. There's now a heat-stable form of the drug, and it's clearly complicated. However, he made out like a bandit. At the end of a week, much better. He was starting to get prostanoid symptoms, though, some nausea, some diarrhea. We discharged him from hospital 3 weeks after his original admission. He was functional class 3 at the time. His renal function was normal. He looked great. And in fact, he had lost already by that time, I think, about 40 pounds. But he came back to us about 2 weeks after he was discharged with increasing prostanoid symptoms, nausea, vomiting, headache, diarrhea, really pretty intractable. His echo then showed a PA pressure of 59/64. Right atrial pressure now, 5 to 10. Cardiac output, 4.6 liters. This boy is still a big boy. He's 210 pounds, okay? He was 290. He's lost 80 pounds in 5 weeks, okay? So really dramatic. Some of it was Lasix, most of it was epoprostenol. But he was very symptomatic. So what are we going to do? We're making his life miserable. At that time, we had another, and still do have another prostacyclin analog, treprostinil. It was first released following good data showing its utility with subcutaneous administration. I'm going to show you some data about IV administration, but it has much less in the way of prostanoid side effects. It's a prostacyclin analog. The studies had demonstrated an improved walk distance and hemodynamics, and with retrospective observation, an improvement in survival. There's a big risk of infection. There's a risk of infection with both drugs, but it's almost twice the risk with treprostinil. The drug was originally approved for subcutaneous use. There was a study done in India. This was actually really pretty much of a cowboy study. They actually did a randomized, double-blind, placebo-controlled study with an IV drug. Now what that means is that you're randomized to sugar water being infused through a Hickman catheter, okay? This is a third world country, and they justified it by saying these people would have nothing otherwise. And even with that, they did very well. You saw an improvement in walk and a marked improvement. Most of the patients were functional class 3 or even 4 at enrollment. At the end of the 12-week study, functional class improved. The study was stopped early because of the high risk of infection. But the data is the data. The drug proved good even with IV usage. And a similar study, this time switching patients from epoprostenol to treprostinol done in the United States, showed that the walk distance, which we often use as a surrogate for efficacy, remained stable. So we made the decision to switch him to treprostinol IV. His GI symptoms, nausea, vomiting, diarrhea, headache, improved dramatically. He was still improving clinically. We got him out of hospital. 2 months later, we reevaluated him. His cardiac output's now up to 7.6 liters. His PA pressure's 55, no signs of heart failure. We're congratulating ourselves. He's still got GI distress. We reevaluated him, found to have a nutcracker esophagus. At this point in time, I have somebody who's functional class 2 or approaching that. So the question is, can we further mitigate his therapy, make it simpler? So there'd just been a study published. Revatio, which is sildenafil, was FDA approved for the treatment of pulmonary hypertension, and the second study was done where it was added to background therapy with epoprostenol in stable patients, and they even showed, those patients showed an improvement. So I was hoping that because sildenafil can relieve nutcracker esophagus, and we know that it's additive with a prostanoid, I was hoping to get a double whammy. I was hoping to help his GI symptoms, and maybe because I was getting added benefit, to decrease the prostacyclin. And of course, this is where the PDE5s work. The nitric oxide pathway. Nitric oxide is a freely diffusible gas that's elaborated from endothelial cells, used to be called endothelially derived relaxing factor. When it's generated from nitric oxide synthase within endothelial cells, we know that NO synthase is actually decreased in PH patients, so they make less of this stuff than a normal patient does. NO binds to and activates guanylate cyclase, which turns on cyclic GMP, producing vasodilation and inhibiting proliferation. Cyclic GMP is broken down in the lung by phosphodiesterase 5. PH patients have boatloads of phosphodiesterase 5 in their lungs, more than a normal patient does. So maybe if we could block phosphodiesterase by using a PDE5 inhibitor, we'd have more cyclic GMP and therefore more downstream good stuff. And that was the rationale for the development of the whole drug targeting of the phosphodiesterase nitric oxide pathway. And there are now 3 drugs that do that: sildenafil, tadalafil, and more recently riociguat, which is a guanylate cyclase stimulator. Sildenafil is a PDE5 inhibitor. It's oral administration. It's 3 times a day dosage. It's been shown to improve walk, functional class, hemodynamics, and quality of life indices in patients with pulmonary arterial hypertension. And here you see the improvement in walk from 4, 8, and 12 weeks from placebo, 20 milligrams, 40 milligrams. This is relative to placebo, and 80 milligram dosages of sildenafil. The approved dosage is 20 milligrams 3 times a day. Side effects: nosebleeds, nasal congestion, etc. This is the PACES study. This is when you take stable functional class 3 patients treated with epoprostenol and you put them on either sildenafil or placebo. And what was important here is their walks improved, their functional classes improvement, clinical worsening decreased, and there were actually fewer deaths. So there are actually 2 survival studies now in pulmonary hypertension, one the original FLOWLAND study and one this PACES study showing a benefit with the drug. Here you see the improvement in walk relative to placebo. And of course, this is the improvement in clinical worsening when sildenafil was added to background epoprostenol. This is tadalafil. which is another PDE5, which we did not have when I was treating this young man, but which has now been approved on the basis of its efficacy in improving walk distance and time to clinical worsening in a 16-week trial. And the dosage of that drug is 40 milligrams, so 2 20-milligram doses once a day. And that also showed an improvement in clinical worsening. Here's the 40 milligram group compared to the placebo in the red line. And I'll just say a word as well about the soluble guanylate cyclase stimulators. Same pathway, targeting the NO pathway. The rationale here is there's not much NO around in these patients, so there's not much activation of guanylate cyclase because there's nothing to trigger it. These drugs in this class, will activate guanylate cyclase in the absence of nitric oxide. So perhaps a better drug. We don't know if it's a better drug, slightly different mechanism of action. I apologize, this slide is so busy, but this study was relatively recently published. Very large study showing an improvement in walk distance. That was the primary endpoint here in the treated versus the placebo patients. But also very importantly, this is the effective approved dose, 2.5 milligrams 3 times a day, an improvement in adverse events. So fewer hospitalizations for worsening pulmonary hypertension, fewer people whose walk deteriorated. So clearly benefit from all targets of this drug. When I saw this patient, we only had one, which was Revatio sildenafil, and so we put him on sildenafil, and he did much better. We were able to down titrate the treprostinil, but he still had some persistence of prostacyclin symptoms. Now he was a clear functional class 2. So if somebody walked in your door today and they're functional class 2 pulmonary hypertension, you would not be treating them with an IV epoprostenol or IV treprostinil. You would be going largely with an oral therapy. So using that logic, we said, well, why don't we try taking him off the prostanoid, putting him on another oral drug, and see if we can completely get rid of the limitations and the inhibitions of his current sense of well-being that were largely related to prostacyclin side effects. So no signs of heart failure, walking well. So we decided to consider him for a transition off of a prostanoid and onto a third class of drug. And these are the endothelin receptor antagonists. Endothelin is an extremely potent vasoconstrictor. It's very, very high levels in all forms of pulmonary hypertension, particularly actually the connective tissue disease patients. It binds to A and B receptors on smooth muscle cells where it causes vasoconstriction. But endothelin actually is also ubiquitous, and it binds to many, many other sites, some of which may have relevance for pulmonary hypertension. So you can see it's elaborated by endothelial cells, bound to smooth muscle cells, but also to fibroblasts, where it causes collagen deposition and increased fibrosis, myocytes, where it can cause hypertrophy, which is a good thing, and inotropy, which is a good thing. It can bind to the adrenal glands, where it elaborates aldosterone and causing salt and water retention, and to monocytes and macrophages, where it can be part of inflammatory changes. So these are the currently available endothelin receptor antagonists. There are 3. Bosentan was the first, ambrisentan the second, macitentan the most recent addition to this group class of therapy. What the ERAs do is they bind to those receptors on the smooth muscle cells. And in the case of bosentan, which was the first drug, we found it's an oral agent. This is the approved dosage, 125 milligrams. It improved 6-minute walk, hemodynamics, functional class, time to clinical worsening, and retrospectively survival. But these drugs are hepatotoxic. They're also very potent mitogens. They're contraindicated if somebody is breastfeeding or is contemplating pregnancy, which, by the way, none of our patients should because it's still associated with a 30% mortality. These were the walk improvements in the 2 different doses of drugs relative to placebo. The improvement in 16 weeks in clinical worsening. So only 5% of the patients who received the active drug therapy these were functional class 3 patients at enrollment. experienced death, hospitalization, transplant, withdrawal from the study due to clinical worsening, or initiation of IV epoprostenol therapy, as opposed to 25% of the placebo-treated patients. And if we looked at actual observed survival in open-label extensions compared to the NIH predicted survival, marked improvement. So, good evidence that the ERAs would work. What are our choices? At that time, the other drug was ambrisentan, an endothelin A selective receptor antagonist. Clinically, that probably doesn't have much relevance, but once-a-day dosing and same mechanism of action, but a substantially better risk-benefit profile, such that at this point in time we don't even have to do liver function testing on these patients anymore. Because it's not broken down through the cytochrome P450 system, it doesn't have any interactions with other drugs largely, unlike bosentan, where it totally messes up contraceptive therapy, for instance. And here's the data improving walk distance. This was a US-based study of 5 and 10 milligrams, European study of 2.5 and 5 milligrams versus placebo, marked improvement in walk, and similarly an improvement in time to clinical worsening. And the third entree into the field is macitentan, which is basically a modification of bosentan, the original drug. However, much longer half-life, which allows once-a-day dosing. They did a very long study, which I'll show you the results of. The hemodynamics improved in the sub-study, functional class improved. The endpoint of the study was combined morbidity and mortality. Okay, it was an event-driven study. The very infrequent incidence of liver function abnormalities, so again, LFTs are not required. And here's the results of the study, placebo in the red, and the effective FDA-approved dose here in the dark blue, showing patients the combined endpoint of meeting an event of morbidity and mortality. This was largely driven, though, by morbidity, not by mortality. And similarly, this was patients hospitalized for pulmonary hypertension or death, and again, comparing the active treatment versus placebo, a 50% reduction in hospitalizations, dramatic. So, but this was 6 to 8 years ago. So our choices then were bosentan or ambrisentan. Because of the risk profile and the once-a-day dosing, we chose ambrisentan. Today we might choose macitentan. A follow-up heart cath was done after he'd been on the Letairis ambrisentan for about 3 months, and the epoprostenol was weaned off gradually. The follow-up heart cath showed he still has pulmonary hypertension. We don't make this disease go away. Just like Dr. White doesn't make peripheral vascular disease go away, we just manage it. We do not make this disease, or rarely make this disease, go away. PA pressure 72/30, wedge is normal. Cardiac output 9.4 liters. This is still a big boy. That works out to about an index of about 4 liters in him. And no step up. So, what's the sequence of event? We have severe IPAH, which you've diagnosed in a critically ill patient presenting to your ICU. He was started on epoprostenol. We now have the advantage of heat-stable epoprostenol. He was transitioned to symptoms due to symptoms to treprostinol. We then added sildenafil in an effort to lower his dosage and to get him more bang for his buck. We then added an ERA and weaned off the epoprostenol. Excuse me, let me just go back. We discontinued the prostacyclin analog, and now, and at that time, if further therapy was indicated, we would have the option of going to inhaled drugs. So, future directions. I showed this slide when I first did a lecture on pulmonary hypertension, I think in 1991 at an ATS, and we had the bad guys, the vasoconstrictors, and underproduction of the good guys, and that was where our focus was. This is what the current targets of therapy for pulmonary hypertension look like. And the trouble is, while at the same time this tells us that we have a lot more room for intervention, it also tells us that there's a lot of pathways that interact, and the body has many ways of getting around the things that we're trying to interact with. These new therapies have, however, conferred a survival benefit out to a median of 7.5 years, and this is data from REVEAL. looking at time to diagnosis in the current treatment era versus from the NIH registry. There's also been a change in demographics in these patients. In the US now, this is still a predominantly female disease, but 4-to-1 females to males, and a much older age of disease onset and diagnosis, about 10 years later, age 46. So the other thing we need to do is have therapies that target not just the pulmonary vascular bed, but the right ventricle, because it's very clear that the differences in outcome may well be driven by how your RV responds to load. So this is a normal RV, very simply put, and our patient with idiopathic pulmonary fibrosis. But the RVs don't just look different geometrically and kind of geographically, they're genetically different. I'm not going to go through all of this, except to say that it's clear that patients die of heart failure. So if we could make their pump better, they could continue to handle the sorts of pressures that you saw even in this patient. How are we going to do that? Well, we need to get in earlier with this disease. By the time these patients present, they've got substantial disease involving at least 50% and most of the time 70% of their disease. That horse is not just out of the barn, it's all the way to Portland, Oregon, okay? It's way down the road. We need earlier disease recognition. We need a biomarker. We need a dipstick. We need something like for G6PD that we can tell who's going to get this disease. And further improvements in outcome from new drugs so that perhaps we will not be transplanting these patients in the next 10 years. Thank you for your attention.
Okay, it's much easier being a cardiologist. This is obviously a tough subject and a very, very important subject for our patients. Questions? I saw Dr. Lupercio in the crowd there, and I respect even more now what you do. Dr. Lupercio is one of our pulmonologists. Yes, sir.
Watt is about $90,000 a year. The endothelin inhibitor is about $50,000 a year, and prostacyclin's about, prostacyclin is about $50,000 a year. So if you have someone,
it's more like $130,000 a year.
There you go. So the 7.5-year survival improvement is about $1 million. So what I find that is challenging a lot of times that when I get people that come by, it's really tough to convince them. You know, usually the husband or the spouse is there like, you told me I would have to spend $50,000 a year on this? I don't know how, maybe the bigger centers have an easier time getting approval, but there is a lot of help though. But the initial shock sometimes is very hard to get through.
Yeah. You're absolutely right, this is an expensive disease. Okay, there's no question about this. An analogy I like to use is everybody knows that corneal transplants, right? You can go to your corner drugstore and get a corneal transplant. It doesn't cost anything, and it now means you can see. When they started doing corneal transplants, patients used to die, and they went blind, and they were brutally expensive, okay, in relative terms, healthcare dollars. These drugs are very expensive, there's no doubt about it, and this is an orphan disease. But the way I tend to think about it is, number one, if we can get a better understanding of this disease, then we can apply what we know to diseases of the pulmonary vascular bed that are ubiquitous. They're the heart failure with preserved ejection fraction patients. They are the mitral stenosis patients who have pulmonary hypertension and the surgeon doesn't want to operate on them. They're the end-stage pulmonary fibrosis patient who has some manifestations of heart failure, but whose disease is probably mediated by endothelin and a lot of the other things that are very similar to what is disturbing the pulmonary vascular bed. So it's sort of an exploratory area that's the thin end of the wedge for hopefully developing new and better therapies, not just for these patients, but for other patients. But in the real world today, you're right, it's very expensive. Now, let me ask you something. What do you reckon it costs to get treated for small cell cancer? Okay? Do you know what the mortality for small cell with optimum therapy is? It's a hell of a lot. Well, it's about 5 to 7 years if you're lucky. Okay? So you have a less effective therapy and a smaller survival rate. This disease comes in looking a lot like small cell lung cancer, somewhere between that and squamous cell cancer that is already metastatic. Okay, it's sort of a race to the finish line. It's also probably not hugely different from some of the oncological diseases. So the way to think about pulmonary hypertension, this is a disease that is the equivalent of lung cancer or some of the hematological malignancies. Huge inroads have been made in the management of hematological malignancies. There's not a person in here who wouldn't step up for a bone marrow transplant probably if you had a refractory hematological malignancy, because they could look you in the eye and tell you, we're going to ablate your bone marrow, we're going to give you a bone marrow transplant, a stem cell from you or a bone marrow from somebody else. You're going to have to go on a little bit of Rituxan and a little tiny bit of FK so that you don't end up getting graft versus host, and you may be okay, all right? And that is going to be every bit as expensive, if not more so. So yes, it's expensive, but you need to treat it right, and you need to treat it aggressively because it's as bad as cancer. Yes, ma'am?
Sometimes it's not the problem of just the expense, but trying to get it actually approved.
Yes, yeah. So I'm not sure you all heard that. One of the issues that comes up is, I've just told you about all of these drugs, but if you go back and you see your patient and you do your evaluation and you write a script for Letairis, 5 milligrams a day, you're going to have trouble getting that past the insurance company. And that's because these drugs are expensive. And in the case of almost all of these drugs, with the exception of the PDE5s, they are dispensed basically through a specialty pharmacy. And that is partly a cost control measure, okay, but partly to avoid what's happening, which is anybody who walks in the door who's short of breath and somebody does an echo and their PA systolic on the echo comes back 42, they get placed on a $5,000 a month drug. That's bad medicine. It's expensive medicine, it's bad medicine, it's bad for the patient. So one thing you can do is there are big PH centers everywhere. Most of us co-manage. We're not interested in stealing your patients away from you. We're interested in getting the right patient, the right drug, and the right diagnosis. So you can either call one of them, give us a buzz, we'll see the patient. We can usually get the drug without too much difficulty, okay, and then send them back to you for management as it seems fit between you and us. So co-management's the easiest way to get around the difficulties of prescribing and getting access to these drugs.
In this case study, was the client's smoking and morbid obesity causative factors, or did they just accelerate the progression of the disease?
There's no association between obesity and pulmonary hypertension. If there was, we'd have an epidemic of it in the United States by now. Cigarette smoking is bad, but there's no association between cigarette smoking. Cigarette smoke is itself a vasoconstrictor. The only drugs, or if you want exogenous things that we do feel either with complete certainty or possible highly suggestive that are associated with pulmonary hypertension are the fenfluramine, dexfenfluramine, aminorex, toxic rapeseed oil, methamphetamine, highly likely, okay, and possibly cocaine, although it's a little difficult to tell. That's a possible but not probable. Same logic. If cocaine caused PH in everybody in California would have pulmonary hypertension.
Dr. Fuentes.
Yes, I have several patients who abuse meth.
I'm sorry?
I have several patients with pulmonary hypertension.
Yes.
Who has history of meth
Yes.
abuse.
Yes.
Has that been studied or seen?
It's already been observed and reported. In fact, from here in California, Rich Chanik, who used to be at UCSD, doing the pulmonary hypertension there, made that observation. In fact, he felt so strongly about it, he did routine meth screening and did a meth history in all of his HIV patients, because we know that HIV is associated about 1 in 1,000 with pulmonary hypertension. He found 100% of his HIV patients had also had methamphetamine exposure. Now, that is not true in Europe, okay, where the incidence of HIV and PAH is about the same, 1 in 1,000, but it's certainly a huge concern because methamphetamine use is becoming more and more widespread, and it's a huge concern for us. Yes, you're absolutely right.
Is there, you mentioned in pulmonary arterial pressure of 42 on echo. Is there a number for this functional class 2 patient? Is there a number on the echo that would raise a flag and say, okay, we need to be concerned?
Okay, so there's 2 different questions there, because you can have a functional class 2 patient, and I've got them, who can get on a treadmill and run for 20 minutes with a 3% grade, and their heart rate will hit 140, and they scare you to death because even at rest, their PA pressure is 120. So functional class and degree of elevation, severity of the hemodynamics don't necessarily go hand in hand, at least not the PA pressure does. And that, I think, speaks largely to this concept of the right ventricle, what it can do, and what it can do over and above what it's doing at rest. So functional class and PA pressure do not correlate. That's number 1, okay? Functional class and duration of disease also don't correlate. We tend to think of functional class 2 as earlier disease, but I've got patients who clearly were normal as the day is long 2 years earlier, and they now have horrible end-stage pulmonary hypertension. They're functional class 3, but their disease duration is 2 years, as opposed to people who have been functional class 2, and they've been functional class 2 for 15 years. So functional class and duration of disease don't correlate. The bigger question is, what number on the echo is your flag to explain a modest degree of shortness of breath in a patient? If you have another risk factor, for instance, scleroderma, you've got a connective tissue disease patient, and you have symptomatology, short of breath when doing more than the activities of daily living, and you have an echo that suggests maybe a PA systolic of 40, okay, and maybe you have one time when the BNP was up, okay, that patient has a high likelihood of having pulmonary hypertension. If that's no scleroderma, no HIV, no portal disease, okay, no BNP elevation, and somebody who's functional class, complaining of some level of shortness of breath, and their echo shows a PA systolic of 40 or 45 or 50, the likelihood that they have got pulmonary arterial hypertension on hemodynamics is going to be very low. It's going to be about 5%. And the people that we can thank for that information are all those lawyers during the anorexia litigation who used to do echoes on everybody and their dog if they took one dexfenfluramine pill and complained of shortness of breath. Because we were doing on heart caths on people whose echoes were mildly suggestive, 30, 35, 40, and what we found is if the PA systolic in the echo isn't over 50, in that otherwise low-risk patient population, the likelihood of your finding PAH is really small. Now, Hap-Farber did a very nice study from Reveal correlating echo and actual measurement of hemodynamics, and I can do as well closing my eyes and throwing a dart at a board, because they really can be hugely variable. You can have somebody where the PA pressure is estimated at 90, and you do the heart cath and it's 22. And they usually tend to be young, healthy males or females in the childbearing age. The other way around, liver patients, you do an echo, the PA pressure is absolutely normal. They pop the swan in because they're taking them in for their their liver transplant. The PA pressure is 90/40, and they roll them out of the OR. So the discrepancy goes both ways, unfortunately. We need a better screen.
One final question. When do you decide to anticoagulate?